For this session, we will be discussing all about ptosis. So what is ptosis? Ptosis is the drooping of the upper eyelid below the normal position. So normally what happens is the upper eyelid usually covers about 2 millimeters of the top portion of the cornea. Okay, this is the normal position of your upper eyelid. The normal position of your lower eyelid is at the limbus of the eye. Okay. Now, if the drooping is below 1 to 2 millimeters or more than that, then it is known as ptosis. Okay. Now, ptosis is usually seen due to the weakness of two muscles, the levator palpebrae superioris muscle and the Muller's muscle. Okay. Now, ptosis can be unilateral or bilateral. First of all, what are the types of ptosis? We have a congenital ptosis and we have acquired ptosis. Now, congenital ptosis can be of various types. The normal common type is your simple congenital ptosis. You can have congenital ptosis associated with the weakness of your superior rectus muscle of your eyeball as a part of your BLEPHAROPHIMOSIS syndrome or as a part of your congenital synkinetic ptosis. Okay, so these are all your congenital ptosis. In acquired ptosis, it could be neurogenic, myogenic, aponeurotic or mechanical type of ptosis. We are going to discuss all this in detail. Coming on to your simple congenital ptosis. Now, this is mainly due to the failure of your neuronal migration or a development with a muscular sequelae, which is seen. Okay. Now, minority of these cases are hereditary. Okay. These can be both unilateral or bilateral in cases. Okay. Now, what happens here is there is an absent upper eyelid crease and there is very poor function of the levator palpebrae superioris muscle, which is seen in such cases. Refractive errors are usually common in such cases. As a compensatory mechanism, a chin elevation is seen in these children. Okay, so because of the ptosis, the eyelid is drooping. In a normal position of gaze, they are not able to see anything from the ptotic eye. If it is a bilateral condition, they are not able to see from either of the eyes. So what do? They have a chin lift. That is, when they lift their chin up from the down portion, the eyeball moves down and they are able to focus at a thing. Okay, so if it is a bilateral condition, a compensatory chin elevation will be seen in such cases. Coming on to BLEPHAROPHIMOSIS syndrome. Now, BLEPHAROPHIMOSIS syndrome, in addition to your congenital ptosis, the child will have BLEPHAROPHIMOSIS, that is small palpable apertures of your eye. There will be telecanthus. Telecanthus means the medial canthi of the eye of both the eyes appear to be further away from each other. That is, the eyes are placed a little away from each other. Telecanthus. And there will be an epicanthus inversus. Epicanthus inversus means there will be an extra fold of tissue which will arise from your lower lids and curve upwards. Okay. So these are the 4 components of your BLEPHAROPHIMOSIS syndrome. Coming on to the Marcus-Gunn winking syndrome. This is mainly, another name for it is called congenital synkinetic ptosis. Only 5% of congenital ptosis comes under Marcus-Gunn winking syndrome. Okay. Here what happens is a branch of your mandibular division of your 5th cranial nerve is misdirected towards your levator muscle. Okay. Usually these are seen as a unilateral ptosis. So what happens in these conditions is there will be a retraction of your ptotic lid, which will be seen in conjunction to a stimulation of the ipsilateral pterygoid muscle. So if your right eyelid is ptotic, it will start retracting when the ipsilateral pterygoid muscle is stimulated. When is it stimulated? When there is a movement of your mouth, as in chewing action, or opening of the mouth, or sucking action, or side to side movement of your jaw. Okay. So whenever the pterygoid muscle moves, the ptotic lid retracts. Okay. This is what is known as your Marcus-Gunn winking syndrome. Okay. Usually this will be noticed by the mother when the child is having the breastfeeds or while the child is eating. Coming on to acquired neurogenic ptosis. These are usually caused by innervational defects. There will be different or bizarre kind of movements of your upper eyelid which will accompany various eye movements. So with eye movements, the lid will go in different positions other than the normal. Usually the conditions where you see this are either a third nerve palsy, a Horner syndrome, in cases of ophthalmic migraine, and in multiple sclerosis. So these are all conditions where you can get an acquired neurogenic ptosis. Coming on to the acquired myogenic ptosis. Now here there will be an acquired disease of the levator palpebrae superioris muscle. Okay. So the LPS muscle has to have some kind of pathology because of which you will get a myogenic ptosis. You can have a myasthenia gravis, or there can be a trauma to the LPS muscle of that side. Dystrophia myotonia, ocular myopathy, or oculopharyngeal muscle dystrophy. So anything which causes a problem in the muscle as such will cause a myogenic ptosis. Coming on to the aponeurotic ptosis. Now here there are defects to the levator aponeurosis in the presence of a normal functioning muscle. So the muscle is functioning normally, but there is a problem in the aponeurosis of the muscle by itself. Okay. So what are the conditions? You can have an involutional ptosis, you can have a post-operative ptosis, or you can have a traumatic dehiscence or disinsertion of the aponeurosis. Okay. Now, in these cases, the clear-cut thing that we will note is a high upper lid crease, which will be more than 12 millimeters in distance. Okay. It will be 12 millimeters or more, the crease from the lid margin. Coming on to the clinical evaluation of a patient with ptosis. So we need to take a detailed history. The examination has to be done in detail, and there are some special investigations that we will do to find out as to what type of a ptosis it is. In history, we need to ask the patient or the guardians as to what was the age of onset of the ptosis. In addition to that, if there was any family history of ptosis, you want to see if it is a hereditary condition or not. History of any trauma to the eye. If there is any previous eye surgery that has happened. Also, if there is any variation in the ptosis depending upon the day, the time of the day. Okay, so in the morning it is better, in the evening it gets worse, or while the child is eating there is a variation. So you need to know what type of variation is present in the ptosis. If there is any improvement with sleep, so the patient was very sleepy and there was a lot of ptosis, but once he slept and woke up, the ptosis became better. Okay, so those kind of variations we need to note down. If there is any worsening with activity, okay, so these are all things which we are trying to rule out myasthenia as such. Okay, coming on to what are the points that we need to look for in particular. We need to see if the condition is unilateral or bilateral. What is the function of the patient's orbicularis oculi muscle, if it is good or if it is bad. If the eyelid crease, is it present or is it absent? Because in a simple congenital ptosis, there will be absence of your eyelid crease. If there is a presence of your jaw winking phenomena, by which you know that there is a misdirection of your nerves which is causing this problem. Then if there is any associated weakness of an extraocular muscle which is seen. Also, you need to see if the Bell's phenomena is present or absent. What are the examinations that we are going to do in a patient with ptosis? So first and foremost, we need to examine the amount of ptosis that the person has. So if the patient has a unilateral ptosis, what we need to see is, we need to see the difference between the vertical height of the palpable fissure. Okay, so normal palpable fissure, so if this is your eye, so this is your vertical height that we are trying to measure. Normally this is about 10 to 11 millimeters. Okay, so you are comparing the vertical height of your palpable fissure of the normal eye as well as the ptotic eye, according to which you are finding out how much ptosis is there. This is in a unilateral case. But in a bilateral case where both the eyes are having ptosis, what are we going to do? So we are going to see the amount of cornea that is covered by the upper lid. So normally we know that the upper lid covers about 2 millimeters of the cornea. So here we will measure one eye and the other eye as to how much of the cornea is getting covered by the ptotic lid, and then we will decide how much the ptosis is. Okay, so if it is 2 millimeters only, then it is a mild amount of ptosis. If it is 3 millimeters, it becomes moderate. If it is 4 or more, it becomes severe ptosis. Coming on to another measurement that we are going to do, it's called the marginal reflex distance. In marginal reflex distance, you have two types of measurements, the MRD1 and the MRD2. In MRD1, the patient and the examiner are at the same level. Okay, the patient is supposed to look at the normal gaze right in front. Okay, and the examiner holds the torchlight and shines it into the patient's eye. We are trying to measure from this reflex, the reflex of the light which is shining into the patient's pupil. From here, we are trying to measure up to the distance from here to the center of the upper lid. Okay, so similarly here in the ptotic eye. So we are trying to measure the distance from the dot, that is your reflex of the light into the patient's eye in the pupillary area, till the midpoint of your upper eyelid. Okay, once we get the distance, we know how much is the MRD1. Okay, this is basically to indicate the degree of ptosis or retraction. Clear? Coming on to marginal reflex distance 2 or the MRD2. Here what we have to do is, from the corneal light reflex in the center portion of the pupil, we have to measure to the lower eyelid. Okay, So in the first one, we measured upwards towards the upper eyelid. In MRD2, we are going to measure to the lower eyelid. So from here till down and here till down. Okay. So here what are we going to do? We are going to see for reverse ptosis, such as in Horner syndrome, or amount of lower eyelid retraction. So in this case, if you see, normally what happens is the lower eyelid is supposed to sit at the limbus of the eye. But here you can see that you are able to see some amount of sclera under the limbus. So there is a retraction in this eye. Okay. So that you will be able to assess with your MRD2. Okay. Now, suppose you want to measure the amount of unilateral retraction. So what will you do? You will do MRD2 of the normal eyelid minus the MRD2 of the abnormal eyelid. This will give you the amount of unilateral retraction. Okay. Now, if you wanted to measure the amount of bilateral retraction, you will have to, for each eye, from 5.5, reduce the MRD2 for each eye. Alright. Similarly, if you want to find out how much is the palpable fissure height, what will you do? You will add MRD1 to MRD2. Okay. Coming on to the levator function, how do you assess this? This is done by BURKE'S method. Okay. So, we have to sit opposite to the patient and the examiner has to keep a thumb on the patient's eyebrow. Okay. This is to negate the action of the frontalis muscle of the patient. You don't want the patient to use the frontalis muscle. You want them to use only the levator palpebrae superioris muscle. So you negate the action by doing this. Then you ask the patient to look down completely without moving the head. Only the eye has to move down, and then you measure this, and again you ask the patient to look up fully as much as possible. The measurement of excursion is noted down. Okay. This is the amount of levator action that the person is having. Now, based on that, you will grade it. If it is 15 millimeters or more, it is a normal levator function. If it is 12 to 14, it is good levator function. If it is 5 to 11 millimeters of excursion only, then it is fair. If it is less than 4 millimeters, it is supposed to be poor levator function. Okay. So this is how you measure the levator function by BURKE'S method. What are the special investigations that we will do? Okay. The first one is known as your tensilon test. Now this is done when we are suspecting the patient to have a myasthenia gravis. We will give an injection of edrophonium and the changes are observed. Phenylephrine test. This will be done when we are suspecting a Horner's syndrome. Other full neurological investigation of the patient has to be done because we want to assess what is the effect of other cranial nerves in the patient. What are the extraocular muscle movements, if any other involvement is there. Okay. In addition to this, if it is a child or even if it is an older person, we ask them for photographic record. That is, from the time when they have started noticing the ptosis, we are asking them to bring pictures from before that time and this duration. So we are trying to see if there is an increase in the ptosis, when did it start, when did it become very obvious. So you want them to bring photographs to show you that. Okay. A Schirmer's test is also done. You can use fluorescein test or you can use rose Bengal test. Why are we doing this? We are trying to assess for the corneal dryness. We do not want the patient to have any pathology in the eye before we take them up for the surgery. So what is the treatment? If it is a congenital ptosis which is of mild or moderate degree, the treatment, basically the surgical treatment, can be delayed till the child becomes 3 to 4 years of age. But if it is a severe ptosis which is causing and stimulus deprivation, that is, if the pupillary area is getting blocked, that means the eye is not getting any kind of stimulus, okay, because of which what will happen is after some time the brain will stop recognizing that eye and the patient will go into amblyopia. To prevent a stimulus deprivation amblyopia in a severe ptosis, a surgery has to be done at the earliest possible chance. How do we decide what type of surgery are we going to do for ptosis? This is based on the degree of ptosis and the function of your LPS muscle. Now, if you have a mild ptosis with good levator function, then the surgery of choice is your FASANELLA-SERVAT procedure. If it is a mild to moderate amount of ptosis with a levator function which is there, then we can do a levator resection. The amount of resection will depend on how much amount of levator function is there. Okay. If you have a severe kind of a ptosis with no levator function, then the treatment of choice becomes your frontalis sling surgery. Okay. Coming on to what exactly is your FASANELLA-SERVAT procedure. This is done for mild ptosis where the levator function is good. That means it has to be at least 10 millimeters. Okay. Most of the cases of your Horner syndrome or your mild congenital ptosis, all of them will come in this. So we can do a FASANELLA-SERVAT procedure for all of these cases. Okay. Now what we do here is the upper eyelid is everted. Okay. And the upper border of the tarsus is excised along with the lower border of your Muller's muscle and the conjunctiva which is overlying it. So you folded it and held it on. So the top part of your tarsal plate and the lower border of your Muller's muscle all are cut and the remaining part is sutured. That is your FASANELLA-SERVAT procedure. Coming on to levator resection procedure. Now basically this is done for your moderate to severe ptosis where your levator function is at least about 5 millimeters. Okay, it has to be at least 5 millimeters. Now if it is a moderate ptosis, the level of LPS function will tell you about how much LPS has to be resected. Okay. So if it is a good action of the levator palpebris superioris, then we will cut about 16 to 17 millimeters of the muscle. If it is a fair thing, then we have to do about 18 to 22 millimeters of resection. But if it is a poor action of your LPS muscle, the resection amount becomes 23 to 24 millimeters. Same as your severe ptosis. In case of severe ptosis, with even a fair amount of LPS action, the resection has to be done about 23 to 24 millimeters from the LPS muscle. Now the resection can be done from two sides. You can either do a conjunctival approach or you can do a skin approach. The conjunctival approach is called the Blaskowitz operation and the skin approach is called the Everbush operation. Now, the conjunctival approach is comparatively easy, but it is not suitable for large amounts of resection because it is very difficult to try and see the LPS muscle through the conjunctival approach. Okay. Here we use a Desma's lid retraction to evert the eyelid. The LPS muscle is identified and the amount of resection is done. In the Everbush surgery, here it is more frequently employed procedure because it allows for a large amount of exposure of the LPS muscle. So any surgery which requires large amount of resection, a skin approach is preferred. Coming on to your frontalis sling surgery. Now the indications for this is if there is severe ptosis of more than 4 millimeters with a very poor levator function which is of less than 4 millimeters. Okay, so remember the number: ptosis of 4 millimeters, poor levator function of less than 4 millimeters. Okay, or if the patient has a Marcus-Gunn jaw winking syndrome, or if it is a part of your BLEPHAROPHIMOSIS syndrome, if there is a total third nerve palsy, or if this is a repeat procedure due to unsatisfactory results from a previous surgery. Okay, in such cases what we have to do is we have to do a suspension of your tarsus to the frontalis muscle. Okay, now this can be done with the use of an autologous fascia lata that you can take from the thigh of the patient. Okay, or you can use non-absorbable synthetic material such as your proline and silicone, a band which is used. Okay, so you make 5 openings. 2 are made on the upper eye, just little above the upper eyelid, 1 in the lid slightly above that, and 2 on your tarsal plate just above the lid margin. From under the skin, a needle is passed and your autologous fascia lata or your silicone tubing is passed through all these and it is tied up here. Okay, and all these small openings are sutured together. So this helps the tarsal plate to sit along with your frontalis muscle. Okay. Now, if it is an acquired ptosis, basically we need to treat the underlying cause. In case of a neurogenic ptosis, we mainly go with a conservative treatment. If a surgery has to be done, we usually defer the surgical procedure for about 6 months because we are trying to give the patient time to recover from the neurological process. Okay, and if a surgery is done, then the procedure used is a FASANELLA-SERVAT procedure. Coming on to the summary of what all we have discussed in this session, we've discussed all about ptosis. So what is the definition of ptosis? What are the different types of ptosis? What are the syndromes which are associated with ptosis? How do we do a clinical evaluation? What is the history that we take? What is the examination, the special investigations that we do? And what are the different type of surgeries that we do for ptosis? That's all for this session.